So thanks, Sasha. And on my own behalf, welcome to BSMS. Over the next 50 minutes or so, I'm going to lead you both through a bit of my career in terms of growing up in medicine and in research, but also lead you through a series of questions. And when I talk to students and junior staff, I always try and get them to think about research questions. And these are the questions that I'm going to show you that myself, along with a vast array of collaborators, have worked on over the past 25 years or so. I always ask for research questions because I can never remember the difference between an aim and an objective. But I find if you put research questions, no one ever asks you about those other things. So just a bit getting started. This is the first known photo of me in the late 1960s by Lake Windermere with my mum. You can tell the era by the glasses and the beehive. I grew up not that far from here, a couple of hours away in Winchester. This is me on the climbing frame. I think wearing my Sunday best coat. That's Winchester Cathedral, which some of you may have visited. But I grew up there, went to school in Winchester, and then secondary school in Southampton, back to sixth form college at Peter Symonds College. And we get lots of applicants here, and no doubt elsewhere in the university from Peter Symonds still. I applied to various medical schools, got into St Mary's, and St Mary's was the place that I was keenest on, mostly because the then Dean, Peter Richards, had written a book called Learning Medicine, which really was my only experience of what it was like to go and do medicine, what it was like medical school. I had no family who were medics. I did go and talk to the GP, who was a rather austere fellow, but that was it really. And I read the book, and I thought, yeah, no, I do want to do this. Peter Richards was an inspirational dean, and I think it's a good lesson about the difference a dean can make to someone. I was at St Mary's. As you can see from the middle, there are some things that have changed about me. Me on the bike, perhaps you probably see me on my bike around here still now, and that is, I think it's the third year. I was trying to work out which year. That's the third year. And you remember in those days, they were these big sheets with photos that everyone had before everything went digital. I did an intercalated BSc while I was at St Mary's, and the project I did for that was actually the first experience I had of doing work in pregnancy. This time it was about diabetes in pregnancy. But that was my first sort of experience of doing any research. It was published subsequently by people who were much better at doing it than I was. Following medical school, I carried on, did house jobs at St Mary's, and then I did my surgical job at Gloucester, and then I went back and did a couple of years of hospital medicine before deciding that I wanted to actually do GP, which is what I had gone into medical school wanting to do, but they kind of kick you out of it. Or they did in those days, kick general practice out of you at medical school. But I decided actually that was what I wanted to do. So I went back and did that. But at the end of my GP training, I did want to try and do research again. And so I was lucky enough to manage to get a job at Birmingham, just wrote to various places that weren't too far away, Birmingham, Oxford and Bristol. And Birmingham had a job. And I put a light bulb there because it was a bit of a light bulb moment for me, because I thought I was going to enjoy it. And then in those days, doing junior hospital jobs was really tough, and I was doing sometimes 140-hour weeks and so on. And you slightly lose the love for it, but first day at Birmingham, I came back, thought, this is it, this is what I want to do, and really have kept that up pretty much. It's rare that I come home and I'm really miserable for more than a day or two. Sometimes when the vice-chancellors are horrible to me, but But mostly I really enjoy it, and it's all from that first day, really. I did a master's and led the first bit of work as part of that, which was my dissertation, which we managed to get published. This is my master's colleagues, which I got permission from them to show the pictures, still in contact with them. In fact, I'm meeting up with them in a couple of weeks' time. Alongside the academic work, I had my first job as a proper GP. I joined a practice. You can see here, this is actually my leaving do in 2013, but I was from 97 until 2013, I was in a practice, and we went from an old, running the practice out of an old house to a new health centre, changed all sorts of things, teaching, research, and so on. That was a big learning curve for me, and as you can see, we were all of an age, so we kind of grew the practice together. So around this time, 1999, I applied to do a PhD towards the end of my master's, and this was the first kind of knockback. Now, those academics of you in the audience know that academic careers are just full of knockbacks from the beginning. You get knocked back for grants, you get knocked back for papers, and it's a life of disappointment with intermittent joy, if you're lucky. But the problem is when people like me stand up, then everyone thinks, oh yeah, no, he's just sort of sailed on into the sunset and never had any problem. But the first thing I applied for, and I thought I was going to have to go back and be a GP because my funding was running out, I failed at. So I think that's a really important lesson. The following year, got some bridging, managed to come up with a new project, which actually was about blood pressure this time, and that was the start of my story. So you're here probably going to hear more about blood pressure than you really want to on a Thursday evening tonight, but a bit of background. And to start with, I'm going to make you do some work. Blood pressure is measured in millimetres of mercury, which used to be measured on those old columns. If you go from 150 to 140 in the top number, that's the systolic, that's a 10 millimetre difference. What difference do people think that makes to stroke risk? Do you think, hands up, who thinks it might be a 10% difference if you go down 10 millimetres of mercury? Everyone's looking. 20%? 40%? Okay, it's actually somewhere between 30 and 40% stroke reduction if you go down, or increase if you go up. And between 15 and 20% coronary heart disease risk. So that's why we bother, because treatment makes a difference. There's also a lot of it about 10 million people in the UK are currently having treatment for high blood pressure, but there are plenty of people who aren't recognised as having high blood pressure, several million, and of those that are recognised, maybe as much as a third treatment suboptimal, depending on exactly how you define that. So this was the kind of gap that I came into, and I wondered, well, whose fault is that suboptimal care? And broadly, it's a shared problem. It's shared between the patients, who often find it difficult to take medication, perhaps because of side effects, or just because it's difficult to remember. Professionals often feel like they're on a hamster wheel like this. Most practices will have between hundreds to low thousands of people on their books, and getting that organised, having a system to organise that is not straightforward, and systems often fall over. People often fall out and don't get picked up. So you've got this sort of whole thing that's set up to fail potentially. So I wondered initially about self-monitoring and whether this could have anything to help. So again, another question for the audience. Hands up, who's ever measured their own blood pressure? Okay. So if I had done this at the beginning, that would be much lower, a much lower proportion of you. But interestingly, the very first time that this was recorded was in 1930 in the Annals of Internal Medicine, where some people from the Mayo Clinic described a 25-year-old intelligent male patient who turned up at the Mayo Clinic with I guess, the 1920s equivalent of an internet printout, which was 3 years' worth of blood pressure readings this chap had done. And he'd done it 3 times a day, and if you look here, this is 190. So those of you who know about blood pressure, like Mike at the back, that's really high blood pressure for 3 years. And they saw that his blood pressure changed with diet, with the seasons, and it went up at the weekends, which they put down to the usual diversions of a young unmarried man. So I'll leave you to imagine what that might include. But when I was thinking about this, so it was about 1999, 2000. So this was, those of you as old as me or older will remember that everyone was worried about the Y2K bug and that everything was going to fall over. Most blood pressure was measured by doctors and nurses, not by patients themselves. The monitors were considered not to be very good. Most people would not recommend that you did self-monitoring. And in fact, in 2004, NICE said there is currently no consensus on whether self-monitoring should be used. So this was where I was at. And so my first research question was, can I get people to measure their own blood pressure? And can we do something with those results? Can we actually make a difference with that? And so my PhD, which was funded by the equivalent of NIHR, National Institute for Health Research, which funded most of my research, it was their precursor, NHS R&D funded this. And anyone who does trials at the moment might be appalled, but I did a trial all on my own pretty much. I had a half-time person helping me, over 400 people from 8 practices that I followed up for a year. And I got half of them to measure their blood pressure in the waiting room every month, and if their blood pressure was high, to go and see their GP or nurse and talk about why that might be. The other half just carried on doing what they would have normally done. The outcome was what happened to the blood pressure, and I looked up for a year and followed them up. And what I found was that for the first 6 months, blood pressure in the self-monitoring group did go down compared with the group that were doing usual care. But by a year, that effect had pretty much worn off. I looked in a very rudimentary way at the costs, and it was fairly cost neutral. It wasn't significantly more expensive to do this because we were just having a couple of monitors in a practice waiting room. That wasn't too expensive. So there was something here, but in terms of my research question, can they measure their blood pressure? Yes. Does it make much difference? Perhaps not. So I moved on to my postdoctoral work and started thinking, can you diagnose high blood pressure outside of a clinic? And in fact, this was the first time I started collaborating on a wider scale outside of Birmingham. So this was with colleagues from Oxford, colleagues in hospital medicine, as well as GP colleagues from public health. And I think Jonathan is with us here, who's involved in this. And basically, we started off looking at the literature and said, what's the best way of measuring blood pressure to diagnose high blood pressure? And the literature suggested that the measures that you do outside of clinics, home measurement or wearing a cuff for 24 hours, are more effective ways of diagnosing high blood pressure. So we had that evidence, and then we combined that with colleagues from NICE who did some economic modelling with us. And we showed together that it was more cost-effective as well as more effective to measure the blood pressure. So the extra cost, for example, of getting someone to wear a cuff for 24 hours, more than cancelled out by the extra effectiveness, essentially because you target the right people to get treatment, who are going to get the people who are going to get benefit from treatment. So this is about diagnosis. That led to NICE changing the diagnostic criteria. And in 2011, the UK was the first place in the world to change the diagnostic criteria for hypertension to say you should try and diagnose hypertension ideally on an out-of-clinic measure, on out-of-office measure, ideally with ambulatory monitoring, but home blood pressure as an alternative. Now, this was not entirely well received. And at the British and Irish Hypertension Society, there were people stood up and there was shouting matches. 5 professors wrote to The Lancet and said that, not quite Professor McManus, I think it was just a professor at this time, was going to be responsible for 5,000 extra cardiovascular death events a year, so heart attacks and strokes. And I forget how many, 90,000 years of life lost or something like that. Anyway, it was all going to be terrible. I will come back to this in a minute, but it was quite a hard time, and in the hypertension world there was a lot of toing and froing as to whether it was the right thing to do. So the answer to that research question, I think, is a tick as far as I'm concerned. But as I say, the whole of the I guess the hypertensionologists were a bit divided. So the next thing I started thinking about was, okay, we've done that first trial, showed patients can measure their own blood pressure. It's very, very low tech, very low key intervention. What happens? How do we get them to have an effect that lasts a bit longer, more than 6 months? How do we get this to work properly? What happens if you, horror of horrors, get them to measure their own blood pressure and adjust their own medication? So people will be aware that in diabetes and such, this is really common, but no one had done it in high blood pressure to start with. And in fact, still some people are completely appalled that we ever tried this. We did 2 trials. The first one looked at people who just had high blood pressure. The second one looked at people who had high blood pressure along with things like a previous heart attack or a stroke, kidney disease or diabetes. And again, we randomized half of them to do the new thing, half of them to carry on as they were. And the new thing, or self-management as we called it, it consisted of measuring your own blood pressure, adjusting your own medication, using essentially a recipe that was agreed with your GP at the beginning of the study, and then repeating that process until the blood pressure was under control. And as I said, comparing to usual GP care. And this time, after 12 months, the interventions worked, and they worked in both trials, and if anything, they worked better in the sicker people who were also older. So we had a really good result. We were interested in getting this into action, so we wanted to look at cost effectiveness, and so we did economic modelling for both of these trials and essentially showed that both were highly cost effective, even more cost effective in the older people. So, a tick. Patients can adjust their own medication if you give them the right tools. Around this time, I got the opportunity to move from Birmingham to Oxford. I had just, 2009, I think I got my chair in Birmingham. I did my first inaugural lecture, actually, in Birmingham, then moved to Oxford. I was a fellow at Green Templeton College, which you can see on the left-hand side. This is a view of the garden there. I became switched to a practice in Oxford. At Green Templeton, I got my first role acting as Dean and Dean for Welfare. Dean there is a bit different to Dean here. Wasn't in charge of the whole thing, that's the principal, but the Dean was in charge of, believe it or not, discipline of the students, but also about welfare. And there are about 600 students. So that's a pretty big job, and they're all postgraduate students, and understanding what students' needs were. And actually working in a practice, we looked after a lot of students as well. So got it from 2 sides. On the right is the Department of Primary Care in Oxford, which I joined. And soon after, I got an NIHR professorship, which funded me then for the following 5 years to continue on the work. And one of the first things that I wanted to do then was to think, okay, we've slightly done this out of order. So we've got patients at the centre, we've got them to measure their own blood pressure, we've got them to adjust their own medication. But actually, the evidence that GPs can do the same thing using self-monitored blood pressure hasn't kind of caught up. So we better do GPs next. So again, we got a big group of us. Again, people in the audience involved here. And this was, I wasn't very good at acronyms, so Tasman was the first one, Tasman 2 was the second one, this is the 4th one, guess what it was called. And we randomised 3 groups this time. Usual care, which was still largely GPs measuring blood pressure, patients measuring their own blood pressure and then writing it down on a bit of paper in the middle, and then an early form of an app, which was actually text-based, because in 2015, when we were thinking about this, most patients with high blood pressure had a brick phone, but not a smartphone. So it was text-based, but it was an app, and it gave feedback as well as allowing people to send in blood pressures. And again, we followed people up, and we showed that with this intervention, you got lower blood pressure, those who self-monitored, and those that used the app had lower blood pressure quicker. So at 6 months, the app was significant. At 12 months, both the app and writing it down were significantly lower. And again, we did cost effectiveness modelling, and again, it was indeed cost effective. Now, alongside these trials, we also had been thinking quite hard about diversity, and these trials are certainly just not done by me. They're big multidisciplinary teams, and as well as the trialists and the doctors and the statisticians, we also work really closely with social scientists, and I'm really pleased that some of them are in the audience, and quite famous social scientists are in the audience today, not even including our Vice-Chancellor. But one of the things we looked at was how can we recruit diverse populations, because funnily enough, it's not just old white people who get high blood pressure, it's poor people, it's people from different ethnic groups. And so we spent some time working really hard to try and get a diverse population, and managed, at least to a certain extent, but learned a lot of lessons along the way. Personally, I learned a lot from colleagues, particularly Tanvi Ray, who led this piece of work, about how hard it was, and how hard it was as a woman of Indian origin to go and try and recruit diverse populations. She had white men saying it was going to be easy for you to go into a mosque, and she was going, I'm a woman, and I'm not Muslim, and they think it's easy for me to go into a mosque. So there are lots of interesting things came out of that, and that's one of the papers that actually I'm really proud to have been part of, although I have to say that all the sociological thought came from elsewhere. So that was all linked in with that bit of work, and the conclusion at the end of that was, yes, we can get an app and other self-monitoring to guide hypertension care. But this was an opportunity that I had then to go back, always be curious. So we applied for a grant, and I said, 2011, they said, we're going to kill 5,000, or not kill, cause 5,000 events a year. I want to find out how many we've really caused. And I got the money, and we used routine data to look and see what actually happened. Surprise, surprise, there was no impact on cardiovascular events from this big change in diagnosis. In fact, if anything, if you look on the left, on the right, the left-hand side is what happened before the change. The right-hand side is what happened after. I reckon, although it's not particularly significant, if anything, the right-hand side is lower than the left-hand side. There's certainly no signal there that there's a big jump caused by the change. So that was really personally satisfying. I was going to call the slide academic revenge, but I thought that might be going a bit too far. So we moved on then to say, OK, we've done all this stuff about self-monitoring in trials. Can we get it to work in real life? To do stuff in real life, you have to work with commercial companies. I cannot, as an academic, get self-monitoring interventions working across in all the however many thousands of practices there are in the country. But commercial companies have got the clout to do this, and the clout to develop fancier interventions than us. So they took our work, they took our algorithms, and they turned it into an app. At the top, this is Omron, who are the world's biggest manufacturer of blood pressure monitors, and a GP dashboard. And we did an independent evaluation of what happened. At the point we did this, they had over 3,000 people using the intervention. And what we showed, if you look on the right-hand side, the far column, those minus numbers mean that blood pressure is going down. And again, this is the systolic, the top reading. And both in terms of readings that the doctors and nurses recorded in the record, and the readings that patients recorded and were transferred into the record, both of those went down. On the left-hand side, you can see a graph. You can see here on implementation was in the middle, so the stuff on the left is before, the stuff on the right is after. Before, the green people, who were the people invited in the middle, had higher blood pressure than the blue people, who were the controls. You can see the blue people stays roughly the same level all the way along, and then goes down in the green after implementation, suggesting this is observational work, so it's not as good as a trial, but it does suggest that we're having a similar effect to the trials, which is actually quite good, because normally you get a less effect. Does it work in real life? I think tick. So the question then was, OK, we've done this in primary care, and this happened, I'm slightly going back in time now, but it makes the story work better. So when I was applying for the NHR professorship back in 2012, 2013, I had some conversations that made me wonder whether this sort of intervention might work in pregnancy. And so pregnancy is important because about 10% of women get high blood pressure during pregnancy. And although hardly anyone, thankfully, dies in pregnancy these days, if you look at the women that do sadly die, high blood pressure is often associated. Blood pressure, when we started doing this work, was typically only really checked at antenatal clinics. But women can develop high blood pressure between those antenatal clinics. And so we wondered, could self-monitoring and blood pressure improve the detection and/or management of pregnancy hypertension? And I was really lucky that I cold called Lucy Chappell, who's also with us today, who's now Professor of Obstetrics at King's College, also runs NHR, one of our big funders. But I called up Lucy in the days when she didn't know who on earth I was, and thankfully she agreed to work with me, and that was a big deal. So, what proportion of pregnant women do you think self-monitor blood pressure? And this is as of about 2021. Hands up who thinks it's 20%? 50%? 90%? Okay, the answer's actually 50%. So that's a lot of women measuring their blood pressure. So we thought actually this might work in this group, and they've all got mobile phones as well. So the kind of interventions that we were interested in might work. And we did 2 trials, one about detecting high blood pressure using self-monitoring, one about managing self-monitoring. And as I say, Lucy was very involved in both of these, also Kath Tucker, colleague from Oxford. In bump 1, which is a detection trial, the women measured their blood pressure 3 times a week and then increased that if their blood pressure got higher towards the threshold. Bump 2, when the women already had high blood pressure, and it was about could we control it better, they measured it every day. And we used an app which we developed bottom right-hand corner, and the women sent in readings, again got feedback, this time through the app rather than text, as to what to do. And these were the 2 biggest trials in the literature. In this one, we had about 2,500 people in the detection trial, but unfortunately, we weren't able to show any difference in the time to detection as recorded in the clinical record. But when we looked at what the women had been doing, it turned out that 3/4 of the women had measured their blood pressure around the time of their diagnosis. And if you looked at their blood pressure had gone up nearly a month before it was recorded in the clinical record, suggesting maybe that the thing was actually working, but maybe the problem was that the clinicians weren't necessarily taking such notice of the women. In the treatment study, again, we didn't find any difference between the 2 groups. So the women who self-monitored had equivalent blood pressure control to the ones that did normal care. But importantly, in both of these trials, we didn't find any evidence of harm. And we looked quite carefully at things that might affect the mum, the baby, quality of life, anxiety. We looked at subgroups, age, ethnicity, and so on. There was no difference. There was no signal that we were doing any harm. So we'd got a lot of women measuring their own blood pressure, and felt like probably we weren't quite there, but that there might be something in this. So we then turned our attention to what happens after pregnancy. Now, when women have high blood pressure in pregnancy, about half of them go home on treatment and then gradually reduce those treatment, usually over the first 3 months or so. But, and you might recognise the new dad on the right, when you've got a new baby, it's really hard work. There's all sorts of things going on. This is what the dads are like. Imagine what the mums are like. I mean, many of you will have been there. And trying to manage high blood pressure in amongst new babies and stuff is really, really hard. And it's often haphazard. Midwives look after you for the first 10 days or so, then it goes over to the GP. I'm a GP. And trying to get hold of a GP, as you know, is not straightforward necessarily. And what often happens is women just run out of medicines and then just stop them. And that is not the fault of the women, I would argue. It's the fault of the system. So we wondered what would happen if you got the women to self-monitor and actually more involved in running their own care. And we started this with a feasibility trial, and then we moved on to a bigger trial, which was combined with some clever cardiological tests looking at what was happening in the heart. And we used an app, again, that was developed from the other work. And in the feasibility trial, it was just 100 women, and we wanted to see, could we get this thing working? And we did. The purple line on the left here is the women who measured their own blood pressure and adjusted the medication on those readings. The blue line is the control group. And as you can see, the purple line is below the blue line. And this is only 90 women, but it did have a signal that blood pressure was better controlled. The numbers are the proportion of women taking treatment at any one time. And the really interesting thing here is you can see that the proportion goes from 91% to 4%, but the difference in blood pressure actually stays there. So when the women stop their treatment, there's still a fixed reduction in blood pressure. We followed them up at 3 years, it's still there. That's the graph on the right. So we then went on and did, with about 200 women this time, a very similar trial, but this time, along with blood pressure measurement as an outcome, we did what I would call clever tests, because I'm a GP, and these are things like echocardiography, cardiac MR. And what we showed was that blood pressure effect was the same, and this was 6 to 9 months, and 88% were off treatment at the time. And if you looked at those off treatment, same thing happened. We also looked at what happened in the hearts, and the hearts of the women who had been self-monitoring with better blood pressure control had recovered better after their hypertensive pregnancy, and therefore explaining why we were still getting a difference in blood pressure when they had stopped treatment. So this looks like it could be a long-term intervention that may help with this. Now, both of those trials were done by really excellent clinical PhD students. One of them, Alex Cairns, is now an obstetrician in Oxford, consultant obstetrician. The other one's a consultant cardiologist in Reading, Jamie Kitt. They were brilliant, but they essentially devoted their lives to doing these trials and looking after the women in the trials. That isn't something that you can reproduce nationally. So what we then did was went and got another grant to see if we further develop this intervention and we implement it. This time, 25 sites across the country. We've randomised 730 odd women so far, and we want to see if actually this in real life, not just in a single centre, can actually work, and we'll find out next year whether that's the case. So, tick, can they do it? If you've got a really good clinical PhD person, yes. Can they do it on a big scale? We don't know, and we will find out. So this, all I've been talking about so far is about can people measure their own blood pressure? But alongside this, and in collaboration with a colleague, James Shepherd, who came to me as a very early postdoctoral fellow and is now a professor in his own right at Oxford, we started thinking, could, along with others, and again, others in the audience involved, could people, older people, reduce their blood pressure medication? Now, what you'll be aware of is that when you get treated for high blood pressure, often that's long-term treatment, usually pretty much lifelong. But people get to a point of their life, and we looked at over 80s to start with, where they wonder whether they really should do this. And I talked to my colleagues who in care, geriatricians, and they often stop people's medication, but there's really no evidence to say who this should be done for. It's just done a bit willy-nilly. And we wanted to see if we could have a rational basis for this. And so we randomised 550 odd people, and we looked to see whether if you stopped a blood pressure medication in people over 80 compared with carrying on, whether it made any difference to blood pressure control in the short term. And these are the short-term results which showed that essentially, although it was 2% less likely, that wasn't a significant difference. It was essentially the same blood pressure control at 3 months after stopping in 500 and something people. The problem was that blood pressure did go up a bit, only 3 millimetres, but that's enough if you have it in a population basis to cause problems. So we were a bit worried, but again, this is only after 3 months. So we then followed people up for 3 years from that trial and said, what happened to those people? And we looked at their GP data, their hospital data, and death certificate data. And we were really relieved, actually, to find that in terms of all-cause hospitalisation or death, which was our primary outcome chosen by the patients that we worked with, there was no difference in the people who stopped compared to the people who'd carried on. And more than half of the people who'd stopped at the beginning had still stopped by the time 3 years were up. We looked at blood pressure and there was no difference, and we looked at what I would say bad stuff, things like falls, low blood pressure, fractures, kidney problems. And again, there was no consistent difference, no significant difference really in any of these. That was stopping blood pressure with only 3 month thing, and albeit following it for 3 years, but three months is not long enough to decide whether this is a safe thing to do on a big scale. So we're now trying to randomise 3,000 people to test a similar intervention on a much larger scale. Again, I'm working with James Shepherd and colleagues in the audience in this trial. We've so far got over 2,200 people randomised. We've got to finish it by the summer or by September. And again, 2027, 28 probably will know how that is. So, can older people reduce medication? Yes, in the short term. I think it's still an open question in the longer term. A lot of what I've been talking about is trials. Doing trials on their own is slightly meaningless if you don't have some impact following that. At the beginning, as I've said, in 2004, hardly anyone was measuring blood pressure. Nobody knew that it was a good thing. Now, half the people with high blood pressure in the UK are measuring blood pressure. We've already established that half the pregnant women are measuring blood pressure as well. So this is a really common thing now. When I got you to put your hands up, probably at least half of you put your hands up. So I believe that this is part of the, it's not direct impact, it's indirect impact of coming up with evidence and changing guidance. And changing guidance is really important. We changed the NICE guidance, and then subsequent to that, the US, the European, the Japanese, the Australian, and so on, have all gone on to do similar changes, both recommending out-of-office blood pressure self-monitoring and ambulatory monitoring in diagnosis, but also in the ongoing management. Pregnancy, as you saw, the results perhaps weren't as spectacular, but we did show that proof of concept and that it was an okay thing to do. Subsequently, NHS England recommended that blood pressure monitoring was appropriate to be done by women. US, similarly, they got an early look at our results from those two trials. And the work that we've done has been implemented widely in hospitals around the country. This is just random. This is Southampton, and they've copied the patient information from our trials, and they're using it verbatim for their own women in terms of self-monitoring. This is exactly what we want them to do. So I think we are having an impact. Now the story comes to the move here. Some of family are here. You can see us in the middle, Esther and I and our 4 children. They're all in their 20s now, all really excellent young people in their own right. The opportunity came that we could have quite a big upheaval moving from our family home in Bristol, moving from jobs in Bristol and Oxford and coming here. I've got a new practice at Marlow Medical Centre. I only do Wednesday afternoons these days because I'm here the rest of the time, but I'm delighted to do that. That's what the building looks like on a nice sunny day. You may not have arrived on one of those today, but I'm delighted to be tackling a whole new set of challenges and working with people, hopefully probably more supporting people to do research now as much as doing my own. But as you've seen, we've still got these big trials going on and still doing some blood pressure thing, and with the added advantage, as well as enjoying the campuses both at Sussex and Brighton, but enjoying some of the other things that Brighton has to offer. So I'm going to finish off just with some final thoughts and some thank yous. Getting started as a junior researcher is really hard, and I was extremely lucky that my random letter that I wrote to Birmingham got looked at. Someone actually left a training scheme and there was a gap that hadn't been advertised at the point that I wrote the letter. Kate Thomas, who is the immediate past dean at Birmingham and was the person who recruited me originally, was responsible for supporting me for those first few years, and I'm really grateful. And I would urge anyone who has juniors working with them that getting started is really important. It's really hard. You know, if I had not had support when I missed that first fellowship, I might not be here today. So really grateful for the support I got. Jonathan is here today. Jonathan was my PhD supervisor along with Richard Hobbs. And we shared an office, poor man, just to make coffee together. And Jonathan acted as my mentor. We have published now more than 100 papers together, McManus or McManus, Man. We've got loads of grants. I'm still working on Jonathan's grants and vice versa. That's been really important, and I think I try my best to mentor people. I'm not sure how many mentors. I've got quite a few mentees now around the country, but I think it's really important to support people. Collaborators are really important. As I hope I've made it clear, this is not all my work by any means. I've only been able to achieve this working with large groups of people. That email I sent to Lucy back in 2012 or 2013 or whenever it was really important to me. I had no clue about high blood pressure in pregnancy. I needed someone who knew about it. I struck gold, was really, really lucky to have her, and I'm really grateful that she's with us today. And again, we're well on the way. I think we've done 7 trials together in the last 10 years so far, and it's still going, still planning. Leadership training is really important. I've got a big leadership role now, and I started thinking about this quite early in my career. In 2005, I had leadership training through the College of GPs. And then in 2008, I joined a primary care leadership course. This is us looking all slightly darker of hair and fresh-faced. I had a photo that looked slightly like the one on the right, of us, again, quite young. And one of my colleagues, when I was asking permission, said, we should look a bit older. So one of them said, I'll do that with AI. But he turned us into wizards as well. But anyway, of that cohort, 10 of us, 9 are now professors. The one that isn't, frankly, could easily have been a professor and chose to do other things. So that's been a really good group to grow up with. I think it's also important to say I haven't just done all of this work all along, and I think it's really important to do other things outside of medicine to enjoy yourself. I'm still on my bike. This is Meg, who's a medical student in Sheffield, can't be with us today. If you come to my house, I'll probably bore you by playing guitar. Really like walking and getting out and about. I think this is us on the downs, and I'm trying to learn French because we've got a place, and that's the view out of our window in France. So really important, and I do encourage everyone that I work with not to just do work, because it makes a very tedious life and very difficult to keep it going as well. Some thank yous. Esther is my wife, and is the reason that I can be here in front of you today, frankly. She's a massive support. Esther was previously a very high-flying academic. These days she's much the happier with her hands dirty. This is her on her pride and joy little tractor about to mow our field in France. And I'm really, really grateful for the support that I get, and I'm really aware that I can only do that, do my job really because of that support. Loads and loads of people have worked on these studies. These are all multidisciplinary studies with big teams. I'm bound to have forgotten people, but this is the group of GPs, of public health, of hospital hypertensionologists, obstetricians, trialists, social scientists, health economists. I've probably forgotten others, but massive groups of people. The one I haven't mentioned, which is really important, is the patients. We have patient reps on all of our studies advising us what to do, and they often give us a bit of a telling off and say, why are you doing this? You should be doing that. As you heard, we do ask them about our outcomes and choose the outcomes because of that. This group of people have been really instrumental. NIHR came into being as I was finishing my PhD. They are the major funder of applied health research in the UK. I wouldn't have been able to do this without them. Nearly everything you've heard about today is funded through them. And I really wouldn't have been able to do this without the patients who took part in the studies, without the GPs and hospital clinicians who have helped in the studies, and without the support from the research networks and our research delivery that has helped me along the way. So that is the last thanks, but I've got you in the room. I am going to get on my hobby horse, one of the things that I've been really keen about as Dean. Now, what you might not be aware of is that medical students, when they get to the fifth year, they have about £4,000 less a year to live on than in the fourth year, and it's because the maximum loans that you can get are cut by 4,000 for reasons that are not at all clear to me. This means that students, particularly from ordinary backgrounds, and about a third of our students here come from really, really ordinary backgrounds, what we call widening participation backgrounds. We found students living in cars, and this really upset me. And we started the hardship appeal. And if I realise you're here for other reasons, but if you are able to support this, I would really encourage you to do that. In a month's time, my colleague Harry, who is somewhere at the back, is going to be doing his inaugural lecture, Harry Witchell, which is about physiology, and I would just encourage everyone to put that date in the diary, 19th of March, and I'm going to leave up the QR codes just in case you're feeling generous. Thank you very much indeed.